I've just put a text in the group because I think it's an interesting topic, so hopefully people will join. But feel free to start, Geza, if you like.
Sure. Okay, I'll start then. So it's a funny thing because I don't think we have talked, or I don't remember that we had talked about abdominal ultrasound in NEC, but I want to emphasize at the beginning that I have absolutely no expertise on this. But we do use abdominal ultrasound in some cases, and it has evolved in the past couple of years, and there are some literature suggestive of using abdominal ultrasound. So I just wanted to talk and share some of our cases where we used, and a little bit of what I can understand from the literature of the use of ultrasound in NEC. So it's important to emphasize that these scans were done by the radiologist, so it wasn't done by us, neonatologists. So I will be cautiously interpreting them, but I will try to show some things that were seen and how it changed the management in some of our cases. So we do know that there are some challenges in diagnosing NEC, even though we have the Bell stages, they're well defined, but obviously the clinical features in those are non-specific. X-ray has usually a low diagnostic accuracy. They tend to be specific if you see intramural gas or portovenous gas or free air, but has a generally low sensitivity, and therefore often the interpretation or the report of the X-rays is equivocal. X-ray is even less useful if the abdomen becomes gasless. And really, it's not really useful to specify any cause in cases where the patient is unresponsive to conservative management. And we know that there's a growing interest in using ultrasound to improve diagnostic accuracy in NEC. So I brought a couple of cases. They are in a sort of chronological order in terms of how we started using them. The first couple of cases will be coming from our mortality reviews, where we recognized that in certain situations it was quite helpful to use ultrasound. So there will be more sad cases, but the later on, hopefully, there will be some more optimistic cases. So the first case is a 23-weeker twin baby, spontaneous delivery. It wasn't a fully prepped, was an early intubation and had a quite significant and rocky initial course. Was ventilated, had early PIE changes, were very difficult to manage throughout respiratory point of view, had pulmonary hypertension needing nitric oxide, at periods of hypotension, multiple courses of broad spectrum antibiotics, and we started dexamethasone early on day 10, just because we were entirely stuck. Babies also had pneumothoraces and bilateral grade 3 intraventricular hemorrhage. And then going into day 13, the baby had respiratory deterioration in terms of increased oxygen requirement and had reduced blood pressure, was screened, added meropenem to an already given vancomycin. We treated some with noradrenaline. White cell count was raised, CRP was raised, lactate was normal, and platelet dropped. This is roughly how the X-ray looked like the next day, when the baby had bilious aspirates and blood in stool, and the abdomen was distended. The X-ray was reported to have thickened bowel wall. The baby was put nearby mouth. Antibiotics were changed to a NEC regime, and the blood pressure was improving. Nitric oxide, the noradrenaline was stopped. CRP was stabilizing. Platelet was improving. Surgeons were involved, and they said, treat as conservatively as an NEC. The next day, there was an unchanged clinical status, still minimal bilious aspirates, no blood in the stool. Abdomen continued to be distended, but it was soft with some bluish discoloration. CRP was improving, and we will continue the conservative management. The next day, we could say that clinically there was further improvement. The oxygen requirement was improving, coming down. CRP was static, lactate was still normal, and there was a plan from the surgeons to continue the conservative management. But there were some concerns that the abdomen was discolored. And so the repeat X-ray was done, which showed, as you can see, a fairly gasless abdomen. And then there was the dilemma how we take this forward. So the decision by the team was to organize an abdominal ultrasound. So that's what we have done. And this is the images. So in the left upper quadrant, there were normal bowel loops, and they were well perfused throughout. Similarly, on the right side, there were normal-looking bowel loops, which they were, again, well perfused. But in the left lower quadrant, there was this heterogeneous mass which had no perfusion. There's a bit of video here which shows this sort of mass, which was not a formed bowel, and there was no perfusion through it. So they documented as a small volume free air within the peritoneal cavity, which had some fine echogenic debris. There were large heterogeneous mass and sort of soft tissue with no blood flow in the left lower quadrant. And that was a highly concerning that it was a perforation or necrotic gut. The rest of the bowel seemed to be within normal limits. So based on this ultrasound, the surgeons have done a laparotomy, and they confirmed that there was a necrosis and a perforation in the sigmoid area. They have formed a stoma. Unfortunately, the baby continued to deteriorate and was extremely sick and profoundly hypoxic in the next 2 days, and the decision was to change his care to palliation, and he died. But in this particular case, the ultrasound actually diagnosed the perforation when the X-ray was entirely gasless and was not helpful to pick up that perforation. The second case is a 22-week twin who had, again, he wasn't fully prepped. We had only one steroid. He was early on intubated and had surfactant. Had some blood culture positivity, Enterococcus faecium from day 3 onwards, had a large PDA, but had normal scans. And on day 7, when the UAC was removed, there was significant blood loss. Baby had fluid resuscitation and emergency blood transfusion was given. Lactate, however, continued to rise, and the next couple of hours, the baby developed an abdominal distension and clinical deterioration with increased respiratory support and blood pressure, hypotension needing inotropes. The X-ray was done. It was in the middle of the night, and it was highly suspicious for a free air. But the surgeons wanted a lateral shoot-through, and they were less convinced about the free air. And the onco-radiologists, who were not pediatric radiologists, they were not convinced there was a free air. So the surgeons were reluctant to do a surgery. So we put the probe on the ultrasound probe on the abdomen. I don't have images of these, but essentially those who does long ultrasound can imagine what was seen. Essentially, we did see only A lines. Nothing else was visible in the abdomen. We actually trans-illuminated the abdomen as well, given that the baby was extreme preterm and we could clearly see free air. So the baby went based on that for a laparotomy, which sadly confirmed the total gut necrosis, and the baby died. So in this particular case, the ultrasound was actually confirming pneumoperitoneum when the X-ray, although in retrospect, some would argue, but in the middle of the night, neither the surgical nor the radiology team were happy to say that it's definitely air, free air on that abdomen X-ray. The third case was a 25-week food steroid, had some chorioamnionitis, was intubated, had surfactant, had a brief re-intubation, but mostly was extubated, had full feeds by day 6, had a large PDA diagnosed on day 5, was on paracetamol for that, and had a grade 2 IVH at the early course of its stay. On day 7, had a clinical deterioration with worsening blood gases and distended abdomen. She was put on nail by mouth, started triple antibiotics, chest x-ray, as you can see, showed some consolidation. Abdominal x-ray showed mottled appearance, some thickened bowel loops, possible portovenous gas. The baby's initial CRP was normal, white cell count was raised, surgeons were involved, and they said conservatively treat as NEC. The next day, baby deteriorated further, went on to high frequency ventilation, had a repeat x-ray, which was very similar to the previous day. CRP was raised, lactate gradually crept up to 17. On day 9, there was some improvement in terms of reduction of inotropic support. The abdomen was less distended, it was not discolored, there was no palpable mass, it wasn't rigid. The lactate improved, platelet was still low, and the x-ray, as you can see, perhaps slightly improved, and so the plan was to continue to manage conservatively. And on next day, the lactate remained similar, platelet was again still low, had platelet transfusion. Abdomen was discolored and there was some increased edema around it, but the x-ray showed no significant change, perhaps more collapsed bowel loops. This case, the baby had a deteriorating renal function, so the clinical team felt that there may be a thrombus in the IVC, so that's the reason we requested an abdominal ultrasound, which showed in the left lower quadrant showed some reduced perfusion and some turbid fluid. There was similar free fluid in the right lower quadrant as well, with some hypoperfused bowel loops. You can see some of this turbid fluid. The bowels were not peristalsing, and you can see this echogenic free fluid, same in the left lower quadrant. So what they documented was that there was a moderate volume turbid ascites. The visible bowel were perfused well at the mesentery, but less good flow was seen in the bowels, particularly on the left side. And there was reduced peristalsis as well, and they were thinking that the turbid fluid is most likely because of a bowel perforation. So based on this finding, the baby went through a laparotomy, and the findings were consistent with total gut necrosis and multiple perforations, likely explaining why the perfusion of the gut were not good in any of the areas, and this baby died as well. So again, in this case, the ultrasound showed a complication of NEC and the perforation, when the X-ray actually did not show a free air, which we would use as an indicative of perforation. The next case was a baby who was born at home. We're not sure about the exact gestation. Was mostly on non-invasive respiratory support. There was an initial feed intolerance, but then reached full feeds by day 10. There was a line infection, PET scans were normal, and there was ongoing reflux and desaturations, so the baby was put on different anti-reflux medications. On day 33, this baby had a profound apnea. There was milk in the mouth. There were thoughts maybe there was an aspiration. Started on antibiotics. Abdomen was full and distended and firm. There was some fresh blood in the stool, so the baby was put on nail by mouth. The X-ray showed pneumatosis, but no perforation, so it was thought to be an NEC. White cell count was low at this point. CRP and lactate were acceptable, and so surgeons were involved, and they suggested conservative management. Baby later deteriorated and needed intubation. The blood culture the next day flagged up with an E. coli. A repeat X-ray was done, which showed perhaps fixed loops. That's how it's been reported. I wasn't entirely convinced. CRP was raised, the lactate was still acceptable, so the baby continued to have conservative management for NEC and sepsis. The next day, there was increased ventilatory support. There was a right upper lobe collapse and consolidation seen on the chest X-ray. The abdominal X-ray showed increased dilatation of the bowels. And then there was lack of bowel gas and bowels on the right side. And it was thought that it's probably an inflammatory mass, perhaps a sealed perforation. CRP rose further up, although the lactate was normal. So the surgeons felt that this baby probably needed laparotomy. But before doing that, we requested an abdominal ultrasound, which showed that the bowel looked reasonably well. They were not thickened, the bowel walls. They were good. I don't know which, this one, yeah. So they were good peristalsis, normal looking bowels. They were well perfused. They could see some intramural gas, so probably yeah, so intramural gas. There was some, particularly on the right side, they saw some bowels where the X-ray didn't show air. They showed, the ultrasound showed collapsed bowel loops, but there was no free fluid and good perfusion of the bowels. So they concluded there were collapsed but peristalsing small bowel loops in the right side where the X-ray showed no gas. The colon did not appear markedly thickened walled, but appeared static. There were a few tiny gas bubbles. Similar changes were seen in the transverse colon. The descending colon was distended with content to caliber of 60 millimeter, but again, there were only a few tiny gas bubbles. Small bowels showed otherwise peristalsis and good flow throughout. So they felt it was a feature of NEC, affecting mostly the colon, but there were no other complications or perforation or mass, inflammatory mass seen. So based on the ultrasound, we continued conservative management, and the baby didn't go through a laparotomy. Obviously, we done an LP because of the positive culture. Baby completed 10 days of conservative NEC management and then successfully built up enteral feeds and was discharged home well. So in this particular case, the ultrasound actually ruled out complications that would have needed imminent surgery and was helpful not to do surgery in this baby. The next case is a 24-weeker who had emergency C-section. Mum had an end-stage cancer and she sadly died after the delivery. Baby was intubated, had a fairly rocky start, had unsuccessful extubations, feed was slowly increased, had a consepsis, head scan was okay. On day 7, following an unsuccessful extubation, the baby had pulmonary hemorrhage. The echo showed an unrestricted PDA. We started diuretics and paracetamol. Because of bilious aspirates, the baby was put on nil by mouth and changed the antibiotics to broaden the spectrum. It was low blood pressure. We started some inotrope, and the CRP rose, lactate was marginally increased, and this is how the X-ray looked like at that point. The next day, the baby clinically improved to some degree. Inotropes was stopped. Abdomen was not distended. It was not firm. The X-ray showed some thickened bowel loops and some gas, maybe perhaps a bit of mottling. CRP went further up, and surgeons were involved, and they said treat as NEC conservatively. On day 9, there was some improvement. Baby was off inotrope still. Abdomen was full but firm. X-ray was showing less gas. So we just continued the conservative management. Day 10, There were further clinical improvement from respiratory point of view. Actually, CRP was coming down, lactate was normal. X-ray was quite gasless, as you can see, but the abdomen was, although less distended, there was some people felt that there was perhaps a palpable mass. The surgeons felt that we should continue conservative management. The concern was that for some reason the platelet was keep dropping, and that palpable mass triggered us to arrange and speak to the radiology team. It was on a weekend, so the onco radiologists were called in to do an abdominal ultrasound. And this showed, on the left upper quadrant showed normal looking bowels. They were well perfused. On the right side, again, normal looking bowels, they were well perfused. But in the middle, they found this echogenic mass, thickened wall bowel loop, which had no good perfusion. So their comment was that they felt most of the bowel loops were, there was a collapse loops in the lower abdomen with some increased blood flow demonstrated on the right, but not obvious areas of necrosis and sluggish peristalsis. More prominent loop was seen across the mid-abdomen, and that was thick-walled and some echogenic content, and there was no blood flow in it, and there was no free fluid. Their comment was that they thought this might be consistent with an ongoing inflammatory process. And based on this, the surgeons felt that this is something that they might be worth to do a laparotomy for. So they actually did a laparotomy, and they found a necrotic jejunum, which was removed, and the high stoma was formed. The rest of the bowel were healthy. This baby became very sick following the surgery, but slowly improved, completed 2 weeks of antibiotics. The baby was put on omeprazole because of the extremely high stoma, and it was reversed on day 76, so relatively early. Baby reached full feeds, and although had multiple complications, the baby was actually successfully discharged home later on from the local hospital. So in this particular case, it was felt that the ultrasound picked up a complication like a necrotic bowel that needed surgery. And in retrospect, it was felt that it likely would have made this baby much sicker in the next following couple of days if we hadn't done the ultrasound. And so there was a good window of opportunity to do the surgery when the baby was clinically better. Case 6, 23-weeker. This baby had there was maternal chorioamnionitis. It was stabilized on non-invasive support. There was Lisa given, stayed on high flow until day 2, then got intubated, had a raised CRP. We were treating as a possible GBS infection. The baby had very difficult IV access. On day 6, baby was felt to be clinically well. There was ready to come off the ventilator, but the skin was very broken and quite oozy. Baby was MRSA positive. We were treating as MRSA positive because of the maternal swabs. And later on that day, the baby had low blood pressure, increased oxygen requirements, and raised lactate. The baby had a second long line placed, and the umbilical lines were removed. The abdomen was distended, it was firm and discolored. As you can see on the X-ray, it was quite gasless. White cell count was very low, CRP already raised, platelet dropped, lactate was raised. Surgeons were involved, and they felt this baby is critically unwell with a rising lactate and distended abdomen, discolored. It's most likely a fulminant NEC, possible perforation. So they were planning to operate on this baby. But before doing so, we've done an ultrasound which showed normal looking bowels throughout the abdomen. They were well perfused in both left and right sides. There were a very small amount of free fluid, but they were all clear. So the radiologists documented that they felt it was generally a healthy-looking abdomen, and most likely the abdominal distension was secondary to septic ileus. So we did conservative management in this case. No surgery was done. The baby grew pseudomonas from the umbilical lines and from the chest as well. And although was very sick, and the baby's made through with conservative management and inotropic and antibiotic cover. And although the baby had a very sick course later on, which is summarized here, he was transitioned back to his local hospital, and was, I believe, he was discharged home. So in this particular case, the ultrasound helped us to diagnose, or actually in this particular case, to rule out NEC when the X-ray was not clear and the clinical picture was suggesting a possible abdominal source of the deterioration. Case 7, I think I have, this is probably the last case, or there may be one more. It's a 24-weeker. He was born by emergency C-section. He was intubated in the delivery suite, had a very rocky start with difficult ventilation, pneumothorax, ongoing antibiotic cover for early and possible late onset sepsis. Had a hemodynamic significant duct, which was treated with paracetamol, wasn't really tolerating feeds, and had only small bleeds. Going into day 15, the baby had rising ventilatory settings and a pulmonary hypertension picture, which we started nitric oxide for. We started, they already given antibiotics were changed to vancomycin. CRP was a bit raised, abdomen was soft, non-tender, and perhaps there was some mass palpable. On day 16, the baby's clinical status was unchanged. CRP was static, lactate static, platelet static, perhaps the white cell count as well. Abdomen was minor tenderness and diffuse discoloration. And as you can see, the X-ray showed an entirely gasless abdomen. Then day 17, the next day, there was some clinical improvements with reduced ventilator settings. CRP improved, lactate improved, but there was still a discolored abdomen. So as you can think, we did an abdominal ultrasound. And this showed some clear fluid on the left side, but more echogenic fluid on some other areas on the left. The mid part looked normal bowels. Here we could see some portal gas. So this is the liver, and you can see these echogenic dots. So there was some portal venous gas, but some other areas looked normal. In the left flank, they've seen an echogenic mass. I think it is probably on this video as well. So this bit, which didn't look a normal bowel, it looked echogenic, and it was there was no perfusion through it. So they said there is a heterogeneous mass of the abdominal in the left flank with some calcifications, no blood flow in it. And it looked like possibly in the descending colon. There was some free fluid. Some areas were anechoic, but some areas were containing some echogenicity. The remaining bowels, however, looked normal. There was some hyperemia on the right, and visible peristalsis. There was no obvious bowel wall thickening or intramural gas. They've seen portovenous gas. So they felt that it's most likely a sealed perforation and most likely in the descending colon. And so based on that, the baby went on to having a laparotomy, which has confirmed an old perforation in the descending colon where the ultrasound indicated the problem. There were adhesions as well, forming a mass. There was some bowel rejection, resected, and the stoma was formed. Later, this baby had a very long course. I haven't summarized, he's still an inpatient, but later the stoma was closed. The baby had quite severe chronic lung disease complications, but has been progressing well, and I think is getting ready to be discharged home. So in this case, the ultrasound showed a complication of NEC, like a sealed perforation that needed a surgery when the X-ray actually did not show that, and in some ways the baby was showing clinical improvement. And the last case is a 26-weeker. It was reduced end-diastolic flow. It was a growth-restricted baby, 450 grams, was intubated, had early PIE and pulmonary hypertension needing nitric oxide. Slow was slowly incremented given the severe growth restriction. But on day 10 had an increased oxygen requirement, started on late onset sepsis treatment, primarily with a chest focus, cormoxiclav and amikacin was started and some inotropic support. CRP was a bit raised. On day 11 developed an abdominal distension, so the baby was put on nail by mouth. X-ray was done. As you can see, there were 2 X-rays on the same day. It was becoming progressively less gas in the abdomen. Lactate was normal, CRP rose. The only change on the next day was that the lactate has gone up and the abdomen was discolored, but the repeat X-ray showed featureless, gasless abdomen, and there was no free, some paucity of air was seen, but no free gas. An abdominal ultrasound was then done, which showed some free fluid, which were quite echogenic, but the bowels generally looked healthy and well perfused. In all areas, there was some good peristalsis, but you can see some debris in the free fluid was seen. I think on the right side as well, these echogenic dots. So the diagnosis of the radiologists were there was sluggish peristalsis visible, but generally there was no pneumatosis seen. They've seen this turbid or echogenic free fluid, and so the conclusion was that although they didn't know where it has come from, but it was highly suspicious for a perforation, the rest of the bowels looked reasonably healthy. So the baby had a laparotomy based on that, and that showed spontaneous intestinal perforation. There was no NEC, and the bowel looked healthy. Baby was formed a stoma and had a very long stay, complicated with chronic lung disease, pulmonary hypertension, later a conservatively managed NEC, was discharged to local hospital and sadly had a sudden deterioration and died. So those are the cases. So here there was the ultrasound was helpful, indicating a perforation when the X-ray was not conclusive or was quite gasless. So looking at the literature, so there are quite a few studies and telling what sort of indication ultrasound might be helpful in NEC. In early diagnosis, establishing the diagnosis of NEC when the X-ray is equivocal, demonstrating if the X-ray demonstrates a gasless abdomen, it might be helpful evaluating the complications in a known NEC and evaluating for need of surgery in the setting of clinical deterioration. If we talk about how is it done, generally they say it needs to have a systemic review in all 4 quadrants and the sagittal and transverse position of the probe. Each place should be looked at least 1 minute so the peristalsis can be assessed well. And the focus is looking at the bowel wall, so the bowels, how thick they are, whether they have the usual bowel pattern, it's called signature, its echogenicity, whether they dilated and how they peristalse. We need to look for pneumatosis, whether they are static, which means that if the bowels are moving or the baby is rotated, they remain intramural, or whether dynamic, so that's more likely intraluminar gas. Ascites, whether it's simplex or complex, focal or general, pneumoperitoneum, portovenous gas, and with Doppler reviewing whether the bowel perfusion is normal, hypo, hyper. And if they see Early stage in NEC, we may see bowel wall thickening, indicating an inflammatory process, usually with hyperemia, with pneumatosis or portovenous gas, perhaps impaired peristalsis. And in advanced NEC, we may see thin bowels, diminished to absent peristalsis and absent perfusion. If it's a complicated NEC, we obviously may see a free air, which would be a pneumoperitoneum, complex ascites, which is echogenic, and diminished to absent peristalsis. In some details, these things and a couple of images. So bowel wall would have 5 layers identified. They are in a hyper echogenic. So that makes these 5 layers, although in neonates they say it's often just 3 visible. And to say that the bowel is hyperechogenic, you need to have a loss of clear visualization of the hypoechoic layers. So that's why the bowel wall will look hyperechogenic. Intraluminar gas or intramural pneumatosis can mimic increased bowel wall echogenicity, but this can be differentiated depending on whether you can see a posterior shadowing. Bowel wall thickness. So if it's more than 2.6 millimeter, then we say it's bowel wall thickened. If it's less than 1 millimeter, then we say that this is thinning. If it's thickened, that's more likely because of edema, inflammation, often indicate early ischemia. If it's thinned, then it often indicates a later stage of ischemia or necrosis, or perhaps impending perforation. Peristalsis needs to be looked at over a minute, and then counting the movements, it should be over 10. If it's reduced or absent, then that may be an early sign of NEC or impending perforation. So that's the reason we need to look at each quadrant for at least a minute. Pneumatosis, so I've briefly mentioned, so these bright speckles would indicate free air. Depending on, so if they are mostly in the antidependent areas, and if but the bowel wall maintained, since most likely intraluminar, and then you can test if the babies turn gently whether they are moving or not. If they moved and they remain antidependent, that they would be intraluminar. If they don't move or they are appearing all around, particularly if it comes with the loss of the usual bowel signature, then it's intramural. Ascites, as mentioned before, so it's either can be simple or complex, depending on whether you see some loculation or echogenicity, which is usually indicating of perfusion. So this would be more like so there are definitely echogenicity here. I think there are some echogenicity here as well. So they will all complex ascites. Pneumoperitoneum. So this is what I didn't have an image of, but this is what I talked about at the second case, that if you put the probe, and those who do lung ultrasound and recognize pneumothorax, they know that there will be a reverberation seen only because of the air, so there will be no visible content beyond the free air, and that can confirm pneumoperitoneum with an ultrasound. Portovenous gas I've already showed. I don't think that the video, oh, that may move here, so you can see the speckles into the liver. The perfusion is, there are some descriptions. So in a square centimeter, you need to have 1 to 9 Doppler dots. Then there are description how you should set the scale for the Doppler. And if there is hyperemia, they usually described in 3 different forms: in a circular, in a Y-shaped, or in a zebra-shaped pattern. They all indicate hyperemia. And obviously there can be hypo or absent perfusion. So, so these are the indications that people use ultrasound for. In our experience, I did show some cases where we could establish or rule out the diagnosis of NEC, where we could use very well when the X-ray was gasless. We could diagnose complications or perforations, picking up complications of NEC, seeing particularly if cases were unresponsive to conservative management, evaluation for surgery, either pro or cons. We have used it to clearly diagnose perforation when the X-ray was not conclusive, either it was gasless or just didn't pick up the perforation, and we could see either turgid fluid or pneumoperitoneum. The only thing that we don't use at the moment, but we are talking or thinking, is to use abdomen ultrasound in early stage of NEC to differentiate between NEC or other, like septic ileus. There are some meta-analyses that has some pooled sensitivity and specificity for portal gas or pneumatosis or free air, bowel wall thinning with absent peristalsis, and for detection of abdominal fluid. And in all situations, generally ultrasound is very specific, but have a relatively low sensitivity. So it has a high false negative, but a relatively high specificity to use in NEC. So that's really the end. My summary is that it has a low sensitivity but high specificity NEC. So it is a useful tool in the context of X-ray and clinical findings, but wouldn't be used as standalone test. And we found it very useful in equivocal cases, unresponsive cases, when the X-ray was gasless, to have a better diagnostic precision around the surgery and to diagnose perforation. But we have no experience using it for early diagnosing NEC. Thank you. I'm happy to take any questions if anyone has. I would ask whether anyone has, or do you use abdominal ultrasound, or either yourself or radiologist in the context of NEC?
Hi, Geza. It's Liam here from St Mike's. We certainly do.
Hi.
I think it was in the similar context to you in those cases that are failing medical management mostly, or equivocal X-ray appearances. Often the surgeons wanting to use it to see whether it will push them to take the baby to theatre, or whether they watch and wait a bit further. So yeah, I think the ultrasound experience we have is very similar to yourself. I was interested about if anyone used it themselves, because we would only do it in the context of a radiologist doing it. I appreciate your talks very much about radiologists, but I was just wondering about anyone's experience with POCUS at all, whether actually anyone does it themselves on the unit.
Thanks. Annie?
Thanks, Cesar. I think it's really helpful tool, but as Liam said, at George's as well, it is case by case where conventional methods are not helpful with clinical decision making. I think the only the comment I have is so we just recently looked at our negative laparotomies. So how many times have we gone in where it wasn't indicated? So in last 15 years, we've had 2 negative laparotomies where actually we went in and did not find NEC or a perforation, and so that's actually quite low, which suggests that possibly we are not exploring a lot that shouldn't be. And the second is about the rate of exploration. So we explore 1 in 4 of babies who come with NEC, and with median age of around 4 to 5 days from the onset of symptom. So I think yeah, I mean, it's helpful, but with current conventional methods that we have, we haven't struggled. But obviously, I mean, I think early diagnosis is key, and sometimes I think pneumoperitoneum, when you don't get a very obvious clinical signs, I think it's helpful in doing. But so we have 2 pediatric radiologists who are interested in doing it, and we've had help from them, which has helped us guide, manage. But at the moment, I don't think anyone on the neonatal unit as a neonatologist does this.
Thank you. Mark?
Yes, it's Mark Attard from Aberdeen. To answer your question, I use it. I use it myself. I scan, had some training in Canada, and it's very similar to the slides you have you know, talked about, how the layers, the hypoechoic layers, the perfusion analysis as well, the 9 points. It's very similar to what you've outlined. I just wanted to ask, something I found interesting was that you mentioned that there's a specification as to the gain setting. Can you direct us further to that? Is there?
It is in the paper. I didn't include in my presentation. I don't
Okay.
recall, but obviously to tell how many dots per square meter means a good perfusion.
Yeah.
That has a specific, you know, scale. How you should set your Doppler.
Of course.
Our radiologists, when I asked them, they said they generally just have a gut feeling.
Yes.
Compare it to the other, you know, I presume if you do a lot, you will get a sense of whether is it reasonable, it's hyperemic, or it's hypoperfused or gone.
It's certainly, I find it certainly one of the more difficult ultrasounds to do. You need some time, and you need to spend time, you know, as you say, at least 1 minute to assess the peristalsis. And I also stress the importance of using it as an adjunct, as you've said, an adjunct to X-ray, partly because we're not that experienced in it as well. Thank you very much. Excellent presentation.
Thank you. Mahmoud.
Yeah, thanks, Geza. That was fantastic. Thanks for taking the time to share your cases. So I started using it myself as well, still learning, so I'm not making decisions based on my scan. Like Mark was saying, it's quite actually useful, particularly in the indication where you're not sure is that NEC or sepsis, because that will make a difference in decision. Is that just nail by mouse for only 48 hours or full 7 days with antibiotics? It would be really good to reach that stage. And I don't know if you know, Yasser Said from Canada has done lots of work on this abdominal ultrasound in NEC. Maybe we can invite him at some point to give us a talk about that. But what I found it useful to, you need high frequency probe. So like the hockey stick, you need to set it to abdominal setting, like bowel loop. So it will need to high frequency. You need to deactivate all the harmonics. So because you're looking for artifacts as well. And then you go systematic, as you already described in your talk, 6 areas, vertically and horizontally as well. So still learning stage. So we'll see how it goes.
Well done. Well done. Thank you. Amal?
Geza, thank you very much. This was a fantastic talk, and I would say a great revision that you made us go through. So I do scan, and it is, yes, I think of, if I have to list the most relatively difficult one from a decision-making point of view, because you would get good images, but searching the whole abdomen, I just find that you know, when do you come across the finding that's decision making, it can be a bit explorative. But yes, it is definitely useful, and the kind of babies I get in my unit, they're clearly getting benefit. My last one was a 28-weeker who was getting screened again and again, and was with unequivocal abdominal X-rays, was getting accused of pre-neck sort of situation repeatedly. So I scanned the abdomen and I felt the tummy is not the problem, and there were no other signs of sepsis otherwise. So then I scanned the heart and found a high septal perimembranous VSD and evolving coarctation. So this was a 3-week-old chronologically. So we all thought it's the tummy that's making him desaturate and getting unwell. But in the end, the bowel scan suggested that it's not the bowel. Find the reason somewhere else. Yeah, so those sort of babies they do get, but yes, it's not an easy scan to do. And thank you again for a fantastic talk.
Thank you. Thank you. Any other?
Geza, I must say that your radiologists are very definitive in reporting, which is quite nice, actually helpful, very unambiguous.
Yeah, I did find it very, very reliable what they do. So I think it's been very useful. I don't know whether you have the same experience with the radiologists, because they were very open for us to come and do these scans. As I said, one of them was in the middle of the at a weekend, and they have been very precisely telling where the seal perforation, where the, and they've got it right. Do you have the same experience with your radiologists?
I think it's quite variable depending upon whom you ask to scan. There are few who are very definitive in their reporting, as against there are few who I wouldn't say sit on fence, but would give both the perspective. And sometimes having that definitive kind of opinion is helpful.
Yeah.
But brilliant talk.
Okay.
Thank you.
Yeah, Zoltan's here. So Geza, very well done for putting even 7 cases. I remember I had to give a talk 2 or 3 years ago to talk about how significant and what's the added value of doing whole exome sequencing. And it was just like, when 7 cases, I decided I will never go something like a case series ever. I will just present 1 or 2 cases and that's it, because 7 is just putting the notes and getting everything together. So well done on that.
Thanks. Okay. I think if there's no other comments or questions, shall we close?
Yeah, thank you very much for this lovely
Thank you,
talk.
everyone.
Sorry, quick question. The probe like Mahmood, is it, which one is your favorite, or you go in with the way I do? I just use any probe that gives me better pictures.
Are you asking me? They use
Yeah. I'm asking
I
you.
don't think they use the hockey stick, but they use do you know, Zoltan, which one they use? They use a large abdominal wall.
Yes, that's it.
Probe.
So they use a larger probe, yeah, a bigger one. So it's either 9 hertz or even higher, 11 or something like that. They got.
Yeah.
Do they do it with the G scanner or do they do it with the Siemens?
Siemens.
On the Siemens, they have a 11 hertz linear probe, definitely linear, and on the Siemens they got 11 hertz, just a standard. If you just Google search Siemens 11 hertz linear probe, and the other one on our scanner is 9 hertz, or 9 megahertz, but they usually prefer the big Siemens scanner.
Yeah.
With an 11 megahertz probe.
Okay, because the ones I normally use, you really have to explore a lot. Okay, great. Thank you very much for letting me.
Okay.
Thank you very much.
Thank you very much. Thank you.
Thanks, everyone.
Thank you.
Thanks, everyone.
Bye.
It was brilliant, Geza. Thank you.
Thanks.